The following program was provided by an independent producer solely responsible for its content. The opinions expressed do not necessarily represent the views of this station, its staff, board of directors, or underwriters.
Hello, I'm Carl Seidel, host of The People's View. The show is sponsored by the Nashua City Republican Committee, and if you like to attend our meetings, they're the second Thursday of every month at 6:30 at the Crown Plaza. And if you want to find out more about our organization, you can go to nashuagop.org to see our website and learn about the events that we have.
Welcome to The People's View.
Hello, and help me welcome Don Lebrun, who is both House of Representative for Ward 5 and an alderman from Ward 5. Don, the double shooter here. We're going to discuss the Bill 1696, which is an extension of the Medicaid program that was authorized for 2 years and will end at the end of this year. So I just want to review what's happened over in the legislature so far. Last Thursday, this is January 28th, we were presented with the bill. The bill came out, it was 4 pages long with a 7-page addendum or amendment. They had a discussion for the whole day on the 28th. Then it went to work on the 2nd, right? It was the 2nd of...
The following day we did Tuesday we did a work session, a 3-hour work session.
And then you had an executive meeting that
afternoon.
Okay.
Yep.
And now that you voted on it and the committee approved it to pass with amendments.
Right. Committee approved it 16-0.
16-0?
16-0.
I thought there was a one...
I'm sorry, 16-1, you're right.
Right.
15-1. I'll get it straight in a minute. 15-1.
This is a complex issue. There are a number of people that are concerned about it, whether it just covers a certain plan, a certain appropriate small, relatively small contingent of people who are eligible by extending the limit of the income for eligibility for the program. Mm-hmm. And well, Don, I guess one of the things that I looked at it as an opportunity to maybe alter the plan if possible.
Well, we have altered it. It's been altered quite a bit.
Quite a bit? Why don't you explain
this doesn't really resemble what the original plan resembled. The plan that was in effect, this extension has quite a few changes in it.
Okay,
so
now
it's not the same plan. But when you say it represents a few people, it represents 47,000, almost 48,000 people here in New Hampshire. Mm-hmm. Right here where we're sitting, it represents 14,800 people right here where we're sitting.
In Nashua?
In Hillsborough County.
Oh, Hillsborough County.
Yeah.
Okay.
In Nashua, it represents 804.
Uh-huh.
804 people right here in Nashua.
Maybe you can describe the program as it is now and how the changes come about.
What the program, the new program, the extension, and Medicaid extension is, when you use the word extension, it's not a different program. It's the same program. We're just extending the date from the end of 2016 to the end of 2018. So that's where the word extension comes from. That's all it means. But some of the things we're doing with it, for instance, there's a work requirement attached to it. Mm-hmm. And there's 8 or 10 different ways that a person can satisfy that work requirement. It doesn't always mean that they have to have a full-time job. They can be doing other things. In other words, if you have someone, say, that's addicted to drugs, well, the time that they spend in treatment or in drug court or something like that counts as a job.
Yeah, okay.
Which it should, because they're in treatment, they're trying to help themselves, they're trying to get off the drugs and get clean. Vocational training of any kind. going to school in a vocational school or something. That counts as work time.
So this part is new.
This part is
It
all
wasn't,
new
they
to it.
had no requirement in
Had
the
no
current-
requirement before.
Okay.
And like I say, it's 8 or 10 different things. I can read them off here if you want me to. Subsidized public sector employment, subsidized private sector employment, community service programs. They can go out, it doesn't matter, they can go out and clean trash off the streets as
And-
community service.
Right.
And that counts as
And there are some
work.
exemptions too for people who are ill or medically incapable.
right, disabled, developmentally disabled, mentally ill, that sort of thing. There's exemptions for those.
And you're saying that it doesn't extend the population, and the population is what? I mean, it's the same as it was under the original
Right.
program, and it's made up of families, children,
It's-
individuals.
I have got so many charts here, Carl. I hate to sit here and be looking through charts, but for instance, the enrollment by county, Hillsborough County is by far
The largest.
the largest.
Well, it's the largest county.
male and female is equal up to the age of 25, making up almost 10,000 of the 47,000. Male and female is equal from 25 to 34, making up another 14,000. And it goes on like that. I've
So-
got all the breakdowns of exactly who is on it and why they're on it.
Are these families or individuals? How do they
Some
register?
are individuals because it can be developmentally disabled, which can be an individual. It can be a family. It can be a single parent. For the most part, 32,000 of them, I believe is the number, that are children, innocent children,
32 of the 48,000?
of the 47,000.
47,000?
So the biggest portion of them are children.
Okay.
Innocent children who, through no fault of their own, are in a situation where they need this coverage, where they need health care.
But they're not part of a family?
They could be part of a family in that they're in a single-parent family, or they can be in foster homes.
But that seems like a large proportion of it.
It is a large proportion.
Is there a lot of...
And that's what a lot of people don't understand is this program isn't about, so many people want to say, oh, that's just about lazy adults that don't want to work and things like that. There's no such thing. I hear that all the time. These people are deserving of what this provides them.
These are needy people.
And we have a right, an obligation to provide them with it.
Okay. Well, how do you provide the help, and what is that help?
What do you mean provide help?
Well, is this an insurance type of plan, or is it some kind of the Medicaid, all Medicaid plan?
This plan is entirely different. This plan, you get the federal funds, $250 million. You get, the hospitals have agreed and made a promise to pick up $50 million. And I'll get into what happens if they don't do this later. There are even provisions in here if people want to make donations or gifts or leave an estate or something
So
like
you
that.
have both the
There's
hospitals and the insurance companies contributing something
Right.
In the cost of this whole program.
Right.
And we're reducing the unfunded compensation that the hospital has.
Right.
So far, how long it's been, a year and a half now that it's been running?
Been a year and a half, and it would have sunsetted or terminated at the end of
this year.
2016.
Right.
Now it will terminate at the end of 2018. And there are provisions in here that if any promises are broke, whether it's from the federal government, the hospitals, any of those promises are broke, this thing ends.
Okay. And it just ends, and that's it. They stop getting, in 30 days, you're out of insurance.
Right. And we're not going to let that happen.
Okay.
Not going to let
No,
that happen.
that's what I think people are worried about, is that what's going to happen, an immediate tax levy to support the program?
No.
What's going to happen?
who can predict what is going to happen come December of 2018? We'll be in the same position we were in looking at this terminating at the end of 16.
Okay,
we
so-
had to do something to extend it.
Well, and-
we'll be looking at doing something to extend it again.
We have another 10 months to do that.
Yeah.
But if they stop funding, it ends immediately. You don't have the 10 months. You
If-
don't have 1 month.
That is the way that we guarantee the promises that have been made will actually happen.
okay.
Because it's the end of the program if it doesn't. No general funds whatsoever. None. And it's in here time and time again.
No, but I'm
Absolutely
just
no
wondering
general
how
funds
that,
can be
how
used.
that, you're saying that there's going to be pressure on these people to make sure the money keeps on going at least till the end of 2018.
18, right.
Okay,
That's as far as we extended it.
okay.
So everything has a sunset to it.
But your focus was in making sure that you could extend it and making sure that there was funding to balance the Medicaid federal
Right.
part of the money that
Right.
it's costing.
And the promise that, as far as the funding, that goes for the federal government as well.
Yeah.
If they renege on what they're supposed to do in here, it ends.
Now, does that count the fact that the federal government already said they're going to reduce it so much percent 1 year and then the next year?
That's accounted for in
That's
here.
accounted for.
It's accounted
So-
for. The percentages go down.
And that's when the percentages for the hospital and the industry, insurance industry, go up.
Yeah. Yeah.
Okay. And they've guaranteed that they do it till the end of that period.
I'm not going to use the word guarantee. They have promised.
Okay.
You know, at what point do you say a promise is nothing more than empty words?
Well,
That's why we put it in here, that it ends if they break that promise.
okay. And then there's something to clean up after that. So your aim on this legislation is just the extension of the same program. It doesn't change, doesn't bring any more people in,
Right.
it doesn't change the conditions of the people, so it's the same.
Well, it changes the conditions as far as what they have to produce
Okay,
in order
so
to be
there's a
on it.
performance
Yeah, there is a
requirement.
performance thing. There's also some co-pays involved.
Okay.
If a person chooses to go to the emergency room because they have a cold, it will, even the people on this, it will cost them $8 for an emergency room visit if it's deemed it's not an emergency situation. If they continue to go to the emergency room in non-emergency situations, every ensuing visit costs them $25.
Okay. Now, can you, I don't know if you have any insight. I know you're the vice chair of the HHS committee. My question was, why didn't we look into the performance of the insurance part of it? Is it satisfying the needs of those people? Is there were they the ones that had insurance before they joined the Medicaid extension? Are those people satisfied with how much different is the help they're getting now under the Medicaid program differ from what they did with their insurance?
The information that we received in testimony, it is sufficient. Everybody wants better health care. Even the self-insured want better health care for their buck. These people would like more also, and you can't blame them. I have been on your show before, and I've told you that as far as I'm concerned, and I have a plan that states how every single person in this state can get health care, complete health care, with just a few things that we have to do. I've discussed that with you before.
Right.
That's probably never going to happen,
Why do you
but-
say that?
because my plan calls for abolishing the entire Department of Health and Human Services.
Okay.
It calls for
That's a little change.
Yeah, it calls for eliminating 30% of the employees,
So you have
because there's so
overhead
much duplicity
cut, yeah.
in Health and Human Services that it's just so much fat. They talk about fat in bills in Washington. There is so much fat in the Department of Health and Human Services that we could take all that money, which is 47% of our entire budget,
Right.
goes to Health and Human Services. All of that money could provide health care for every single person
Under
in the
an
state.
insurance program?
Yeah.
With the current insurance, or we have to have insurance across the borders?
Probably have to have insurance across the borders.
So,
Yeah, which is a good thing.
You'd run it almost like our automobile insurance. where
Yeah,
you can get-
very similar, yeah.
So it'd be covered that way.
Yeah.
And you can't get that by your committee,
You
that
can't seem to
concept.
get that, well, can't get it through the House.
Yeah.
We've tried that, we can't get it through.
Well,
I mean,
this
that
is where
doesn't
I
mean we
thought-
don't keep trying.
Well, no, and I think you should. And this is where I had the view that you missed a good opportunity to try a little bit. You could have looked into it and delved a little bit more, other than just getting people to say, well, I know a lot of people on it, they're satisfied. I didn't see anybody doing an external study, if you will, saying that 99% of the people are satisfied with the service they're getting.
We listened for a total of 10 hours, I believe it was, 10, maybe 11
Yeah.
hours, to 103 people and organizations testify on this.
Right?
I don't think there were 5 people who opposed it.
And nobody complained about the service they were getting.
No one. In fact, they praised the service they were getting.
Okay.
I think you attended part of the
I attended
the hearing.
I attended
Did you
the
hear
first
anyone
two. No,
complain?
but it looked like it was set up too. I heard nothing but praise for the thing, and I don't believe any
nothing was set up.
program. No, well, no. All these people that were testifying all had a finger in the pie, if you will,
But-
and they
But
all
the
think
public
it
was
good.
invited.
It was a surprise. It was a late surprise. We
No,
learned
no,
about
no,
it
no.
a couple of days beforehand.
No, I'm sorry. No.
When did that?
We
when did the
knew- we
notice go
knew-
out? You might have known, but it
No,
wasn't public.
The House knew, and it was public in the calendar and everything else, probably 10 days or more before. At least a week, but I'd say probably 10 days. There was plenty of time, the same amount of time when a
What I was
calendar comes
looking
out.
for, even HHS didn't come in. We did a survey. We had an outside group analyzing this. We had suggestions like maybe we can use urgent care so they don't use the emergency room. Hospitals might have added that. We could have looked at
That's
whether
what-
there's other ways. Is that on there?
That's what all of this about the co-pays and the work
No,
requirement and
that's-
everything else, that's what all that's
That's only
about.
one aspect of what the patient has to do. When I'm talking about what the hospital has to do to contribute to cutting the costs. Instead of having an emergency room there and having a triage which says, all right, you're really abusing the use of the emergency room, you got to pay $25. Instead of that, having an urgent care system that people would know to go to even before they come to the emergency room. And only the emergency room
This
is
is going to do the
emergency.
same thing. They're going to know that if they go to the emergency room and it's determined it's non-emergency, that's going to cost them.
But there's no, I would suggest that the hospitals have either an urgent care next to one, like Elliott Hospital. They have an urgent care there, which separates the people. That's not required at any other hospital, is it?
No, it isn't required.
And the hospitals don't seem to like covering the
But
emergency
you
rooms at all.
you can't take this and require a hospital to have an urgent care unit. You
Why
can't
not?
you can't do that through this.
But you could discuss it.
You can't mandate the hospital have an urgent care unit. How are you
No.
going to mandate that?
Well, I'm not sure how. But,
Not through this. That would take a separate piece of legislation,
That could be your recommendation then.
and that's possibly one recommendation that will come around about.
Okay, so there's
I mean,
other things.
there's
other
all
things-
sorts of possibilities.
Yeah.
But right now, we've got to go with what we have passed. We're going to send this on to the Senate, to Finance. Finance is going to do their thing. It'll go from Finance, it'll go over to the Senate. The Senate will go through it, make changes, do whatever it is that the Senate wants to do, and then it may end up in a committee or conference.
Okay.
So
and
this is
yeah.
not done.
No,
It's
I
far from
realize
done.
that. Well, there's no fiscal note
But it's an
either on
excellent start.
there. Well,
No, the fiscal note has not been prepared yet. That will have to be prepared before it goes to the finest
what are the
committee.
elements that they have to look at when developing the fiscal note?
They've got to look at whatever it takes in the way of personnel, computer systems, whatever is involved in administering the entire thing.
Do you have any idea what about that at all?
We have
Your-
no idea whatsoever what that figure might be.
Okay. Do you think that, have you heard in any testimony from HHS whether they're going to need more staff or, I mean, you talked
You know
about
how
the
that
fact-
works, Carl.
Well, that's what I'm
You know how
getting
that
at.
works. Every time you ask someone to do something in government,
There's at least 10
the
people.
first thing they tell you is we need 10 people and we need new computers and everything else. They can come in and say they need anything they want. They're not going to get it.
Well, one of the things that I've always believed is the inefficiency is the fact that the way we set up our computer systems is not very good. There's no.
Well, they don't
talking.
talk to each other.
That's right. And when are we going to do something like that? When are we going to, I mean, as part of your committee, do you ever look into that part of the policy? Get
soon
your
as-
act together?
As soon as they come in and start saying we need a person to make rules, we need computers, we need this staff, that staff, we tell them, no, forget all that, and let's look at what you're going to do.
And how you're going to do it?
And how we're going to tell them what they're going to do and how they're going to do it.
Have you been able to change much in your 4
Sure.
years up there? Or
Sure.
6 years up there?
Sure. We do it all the time.
Okay, well, I haven't seen anything. That's
No, you don't see it because it's eliminated and it's never brought up again.
okay.
No, it's not something that lingers.
No.
We're not going to give them that chance.
Well, but I don't see the money going down at all.
The money is not going to go down.
Well,
The money's going to continue to go up just because of inflation.
No, I'm talking about it's going up more than inflation for the HHS. That's what we did in the last budget. They got a hell of a lot more money.
Well, yeah, but you know that we are only one committee of 127, I believe we're up to now, that are going through the same thing. So just because we say, no, you're not getting anything, doesn't mean that 5 other committees aren't giving them what they
Well, I'm
want.
talking about the HHS budget itself.
Yeah.
I know there's something they
Well, in
have to
6
work
years,
on
the
it.
HHS budget has gone up from 43% of the budget to 47%.
Yeah. And the
And that's
budget
a
as a whole
significant
has gone
increase.
up.
The budget is going up that much. Yeah.
But,
But you can't put that all on HHS.
well, I
You know,
can put a big
we
part
do-
of it on it.
Sure you can. You can put it on any one of those 127 committees.
No, some of them are
You know.
very, very small, Don.
Some of them are very small, but you take small amounts and what do? They add up to big amounts.
Well,
So
I think we still have to work on something like that. And one of the things
there's a lot of work still to be done on this. This is just.
Are you
this-
setting up any other committees to look into any of these situations at all in HHS on a longer term, view? Do you have any committees working on projects? I guess.
We do have some committees working on some things within DHHS, Department of Health and Human Services. I can't say that we've made a lot of headway. Healthcare is such an important subject. It's probably the most important thing on anyone's mind is their health. Without health, you have basically nothing.
But you wanted
So-
to, yeah, go ahead.
So the department is as large as it is necessarily. But what the department has to learn is rather than everything needing a new department every time that something's implemented, there are ways that they can incorporate and mesh 2 or 3 different departments that are doing the same thing and have them administer that whole
Right.
envelope. But that's what they don't want to do. That's what we have to constantly keep after them about and constantly monitor.
I guess that's what I was asking. You
Yeah.
have a long-term project that's doing that?
We have a couple of long-term projects. The mental health issue, we have a 10-year plan to try to condense that plan. We have other 10-year plans. We have 5-year plans. You can't do any of it. You can't just say, as of tomorrow, you're going to make this change,
No,
and
but
you don't do this
you
any
need the
longer.
plan to set it out, set a timeline.
You've got to phase it in.
Yeah,
And-
there has to
and-
be a timeline, some measurable
We have plans
results.
that have been in effect now, have been morphing into the entire plan for the last, I think, 2006, one of the 10-year plans was formed, and that should be coming up with some sort of changes this year. We have others that were started in like 2010, 2012, and they're 10-year plans, so they won't really be, they won't show fruition until 2020, 2022. But there are plans that are taking place.
That's an awful long time period.
Carl, you've been around long enough. You
Well,
know, you know
that's-
how government moves.
That's my
It's
problem
not
with
easy
the
to get
government.
anything done. It's not easy, and it shouldn't be. It should be difficult so that you do it right.
Well, that's the question. When we don't have an opportunity to look into some of it, and all we do is okay, we got a plan, let's keep on funding it, and this is what we'll cover a cost some other way. Because,
Out
I
of-
mean, all this does here, Don, the insurance company and the hospital is going to find out where they get that extra money that they're donating to this program. And guess where it comes from?
It comes
Your
from the
pocket and my
taxpayer. Yeah.
pocket.
Yeah,
Okay, well.
if they renege on it.
Well, no, not if they renege on it. I'm saying the money that they give without reneging on it, it
You
comes
already
from us.
pay a premium. You have insurance coverage. You already pay a tax on your premium.
Yeah. And so what's going to happen now? That's not going to go down.
No, that's not going to go down.
Okay.
But that is funding also that has always been in effect
That's
for this.
right. And where do
And
the
that's not gonna
insurance
change.
companies get their extra money to put their donation in? Where are they getting that?
They're going to get it from premiums from people who have insurance.
Okay, so
That's
now it's
always been the case. That's nothing new.
But that's
been the
what I'm
case for the
saying
last
is
100
that you're not
years.
really saving money. You're just taking it from somebody else. So they're in 3 of my pockets now instead of 1.
If this had never taken place,
Yeah.
you would still be paying that tax. That has nothing
Would it
to
be
do.
any more?
If your insurance premiums go up, the tax would go up.
Yeah.
Yeah.
Yeah. So what? You haven't done anything. All you've done is shift
I don't know why
income.
you say we haven't done anything.
Because all you've extended this, and the money comes from 3 different sources instead of 1.
That's right. That's right.
But it's the same amount of money
No,
that's going.
it comes from one additional source.
One?
The federal funds have always been
Yeah,
part of it.
okay.
The premium tax has always been part of it. And the only difference is the hospital donation. That's the difference. And that doesn't
But
cost.
it all adds up to at least what we've been paying, and that's going to go up as a whole. So I don't see where the saving is, and I'm going to look forward to that fiscal note. Don, when we get
I'm looking
something,
forward to the fiscal note.
and
I want to see it also.
Okay, so this bill now will be voted on in February 10th, is it? I think it's the 10th.
The 10th, yeah.
And then it goes to the finance.
It will go to finance after
Okay.
that.
And so we'll have an idea of what a fiscal note should be developed by that time. So,
Well, the fiscal note would have to be developed by the time the finance committee convenes. So that wouldn't be the 10th.
no.
this would
but
be-
it'd
this would
shortly
go to the
that
floor
after
the
that,
10th.
Because that has to go to the Senate by the middle of March. So
Yes.
there's a 30-day period in
Yeah.
there maybe.
Yeah.
So anyway, Don, we're going to get together again, and we're going to get together with some other people up there, both in the House and the Senate, so we can find out what's happening here, because it looks like a shell game
I
to me.
want to ask you and all your opposition
Yeah.
people, all the people who oppose us, I want to ask you one question.
What?
Which of the
47?
47,404, which group would you like to throw under the bus first?
I'm not throwing anybody under the bus. I want a different program, one that is more effective, one that.
This program is effective. This
I don't see any
program that we
measurements
have
here.
just passed.
I don't see any measurements there. I don't see any analysis of the overall cost there, and the efficiency.
How can
of
you
handling.
have an analysis of the overall cost until you have the fiscal note? We don't regulate the fiscal note. We don't
I
do that.
understand you don't, but you could
The
get
LBA
HHS.
does that.
LBA does it, and HHS should do it. And so that they can compare notes, okay, and see who looks at the analysis.
HHS can't do it until the LBA
Why?
puts out a fiscal note.
No, they can't. Do
Sure.
it on their own, and then you compare the results from the two sources.
Do it on their own would be an estimate.
That's all right.
LBA is more exacting.
I understand that.
That's the number you need, the LBA number, not the DHHS number.
Well, I'd like to see.
To start with, you know the DHS number is going to be totally inflated. Because
Well,
that's the
what
way
it
they
should be.
do things.
Well, then they shouldn't
They
be
come
doing
in
things.
wanting a bucket of apples or a basket of apples in hopes that they'll get one.
Don, we're running out of time, but that's the problem I have. I think every agency should have enough
Okay.
cost control knowledge to know how much they cost. We go into Public Works and we really twist their arms to talk about projects that they run. These are multi-million-dollar projects. Money-wise, they're probably bigger than HHS.
I'm going to make one last statement.
Go on.
I stand behind my vote
Yeah.
on this bill, that we totally and fully vetted this bill, and that this bill has more safeguards in than any health care bill that we have ever had in the State House.
Well, I'm glad to hear that.
And I will stand
Because-
behind it, and I will tell my constituents that there are 47,000 people in this state that need this, that qualify for this. And I am proud to have
I have
seen that
one
they can
last
get
question. There was a larger number supposedly that was didn't have insurance. What happened to the other people that never entered this program?
I don't know what you're talking about. All this is concerned with is the
I
47,000
understand that,
people.
but there were more people that was estimated than, you didn't get 100% of the people that were initially pictured as being uninsured and poverty level.
The facts and figures I have here is as of January 15th, 2016, just 2 weeks ago, there were 46,404 people eligible.
And that's all the eligible people
That's-
signed up.
That's what came out of DHHS. There it is right there. Department of Health and Human Services put this out.
No, my understanding is that's the people that got into the plan, but there were others that didn't get into the plan, never signed up.
They didn't sign up. There's, what can anyone do about that? They're eligible to sign up. If they don't sign up,
My question is, why didn't they sign up?
I don't know.
Well,
I don't
think
know.
that's a question maybe we
I don't
can
know
work
that
on.
anyone knows the answer to that.
Well-
Why didn't they sign up? Why does someone go with nationwide insurance and not State Farm?
Well, I thought it was going to be like Obamacare. If you don't sign up with something, you get penalized.
That may come under Obamacare. This isn't Obamacare.
No, I know this isn't Obamacare.
is not
but
Obamacare.
It's Medicaid.
And a lot of
And-
people like to call this Obamacare.
but it's
not.
It's not that much different than Obamacare.
What in that it's a program trying to help needy people? That's the only comparison that I could see to Obamacare. Other than that, there is no comparison.
We're going to have to look at it a little bit more, Don. Okay, we're running out of it. We've over time. So people, look at the People's View for the next couple of weeks. We're going to be getting into this a little bit more on the overall medical treatment.
You're not going to win, Carl.
Okay.
You're not going to win.
Well, thank you for your time, Don, and the
Thank you.
information you brought with you. And thank you for listening in. And don't forget that the Nashua Republican Committee meets every second Thursday of the month. And don't forget to get out and vote. Thank you very much.
The preceding program was provided by an independent producer solely responsible for its content. The opinions expressed do not necessarily represent the views of this station, its staff, board of directors, or underwriters.